Hello everybody, welcome back to DaVinci Academy's Chapter 4 section of the abdomen, our Lecture 8 on the small and large intestines. The first portion we're going to talk about is the small intestines. The small intestines are composed of the duodenum, the jejunum, and the ileum. The duodenum is the first segment and it's the most important segment because it's a site of predominant digestive enzyme release. The jejunum and ileum are also important because they're predominant sites for nutritional absorption. The duodenum is predominantly retroperitoneal structure, however, the jejunum and the ileum are intraperitoneal organs. And as opposed to the other organs in the GI tract, the esophagus, stomach, the colon, large intestines, all these structures, you're able to kind of figure out exactly where one starts and one stops. However, the jejunum and ileum don't share this well-delineated transition from one organ to the next. Aside from that, it's also important to discuss what are absorbed in these areas in particular. So the duodenum, predominant site of absorption for iron, jejunum is for folate, and the ileum is for B12 and bile acids. The way that I kind of remember this is by the phrase, I fight bad hombres. So duodenum, iron, jejunum, folate, ileum, B for both B12 and bile acids, and then colon for H, hombres, for H2O, water. So I fight bad hombres, iron, folate, B12 bile acids, and water. So the next section we're going to talk about is the jejunum, as we already talked about the duodenum in the chapter on the stomach and duodenum. So the jejunum is an intraperitoneal organ that resides diffusely throughout the abdominal cavity. It resides between the duodenojejunal flexure at the ligament of Treitz, and then it's continuous in a nondescript manner with the ileum. So again, this ligament of Treitz is this little kind of muscular little ligament that attaches the duodenum into the jejunum, holds up this segment right here that allows unidirectional flow of food contents. The jejunum is easily differed from the ileum upon physical inspection, although that's what people say. In reality, it's often very difficult to kind of pick out. The way that I try to pick it out in a gross anatomy cadaver is by looking at the organ itself and inspecting it, that the jejunum's diameter is actually slightly larger than the ileum, and it has thicker walls. Also has less mesenteric fat than the ileum. And lastly, the circular folds in the jejunum are present throughout the length and decrease towards the ileocecal valve. Next is the ileum. So the ileum is an intraperitoneal structure just like the jejunum, and it's also considered to be diffusely throughout the abdominal cavity. The ileum is continuous with the jejunum and then terminates at the ileocecal valve in the right lower quadrant. So probably the most important aspect of the ileum is it contains two things. It contains the ileocecal valve and it contains the Peyer's patch. So first we'll discuss the ileocecal valve. So the ileocecal valve is where the ileum transitions into the cecum. And this is a sphincter where there's actually a sphincter here that allows for unidirectional flow of fecal contents into the cecum and prevents regurgitation back into the ileum. It's also a site of small bowel intussusception in infants or in elderly individuals, and can actually be a location in which ectopic gallstones can actually be blocked. So a gallstone, for some reason, it perforates through the gallbladder, it enters into the duodenum, or it descends down the biliary tree, it enters into the duodenum, will then pass through the jejunum, pass through the ileum, and then actually can get stuck here and cause intussusception and cause abdominal pain. The sphincter muscle at the ileocecal valve is important because at this point in the digestive tract, the fecal content is considered to be mostly liquid. Most of the water is absorbed in the colon, and since the water is not yet to be absorbed, it's pretty much a very liquid stool. And in order to prevent this liquid regurgitation, this sphincter has to be pretty tight in order to stop this reflux. This next section of the ileum that's important is the Peyer's patch. So the Peyer's patch is located in only the ileum and it's not in the jejunum. So if you have a histological slide that looks something like this, this will be only present in the ileum. So what is a Peyer's patch? So the Peyer's patch is actually a group of lymphoid tissue that helps pretty much find any sort of intestinal bacteria or intestinal pathogen that enters in. Again, histological preference of the circumferential lymphoid tissue is a hallmark, a certain guarantee for the ileum, and if you see this, you can almost guarantee that this is not the jejunum. So now we'll go ahead and discuss the blood supply to the jejunum and ileum in brief, as we already discussed this before in the section of vasculature of the abdomen. So all the branches of the jejunum and ileum come from the SMA, and they come from the jejunum and ileal arteries. and they branch off into the arcades and vasa recta right before they enter into the organs. The arcades and vasa recta, although they're shown very well here over to the right in this image, they're often covered by mesenteric fat. However, we'll use this image to the right to help us distinguish which is the jejunal arteries and which is the ileal arteries. So the jejunal arteries, again, have fewer arcades, longer vasa recta. So fewer arcades, 1, 2, 3, long vasa recta. Whereas the ileal arteries have more arcades, so it's more like these little arcades, arches, and very short, quick to the organs, vasa recta. So now we'll discuss the large intestines. So large intestines begin at the ileocecal junction, right here. It contains the cecum, the ascending colon, the transverse, the descending, the sigmoid, the rectum, and eventually the anal canal. The primary function of the large intestines is to facilitate water reabsorption. As you remember from I fight bad hombres, the H in hombres is for H2O, water. Without the large intestines, the stool will remain very liquidy, and in individuals who require a total colectomy and an ostomy, their ileum will then drain to a bag, and because of that, they will actually lose a significant amount of water, and they will often end up being significantly and chronically dehydrated. So while we look at the large intestines are much larger in diameter, and they differ in the small intestines by having three important characteristics. They have the tinea coli, the haustra, and the epiploic appendages. So the tinea coli are these three longitudinal bands that help with the constriction of the large intestines to help with propulsion of the contents through. Although it's this little copper or almost brown-like structure I drew here, there's three of them. So I just drew one though. So as you can imagine, there's three that are longitudinally wrapping around the large intestines. These tinea coli are composed of small muscles that contracts, and this is influenced by parasympathetic innervation from the sacrospinal cord that again pushes food or contents at this point, fecal contents, through this direction in a unidirectional manner. These haustra these are the circumferential bulges. So all these little bulges I drew, these are the haustra. And these are formed by the contraction of the smooth muscle in the tinea coli and help with segmentation of the contents. And then again, at the very end, the last one is these epiploic appendages, where these little fat-like contents that kind of hang off of the large intestines. So now we'll discuss the segments of the large colon. So again, as we mentioned before in brief, the large intestine is composed of the first section, which is the cecum. But before we discuss that, you have the appendix, is this remnant structure here that serves no greater purpose that we know of, that is located at the distal end of the cecum. It's retroperitoneal, and it's a small dilation of the cecum, and it's either present in either a retrocecal or an anterocecal pattern. So it's either tucked up behind the cecum or tucked up in front of the cecum. So although people say it may contain no function itself or may contain some function, the some function is probably some sort of immune response or have some sort of lymphoid tissue present that helps with some immune fighting. However, as you know, appendectomies remove these all the time and individuals still go on to live healthy, long lives. The cecum now is a very dilated portion of the large intestines. It is continuous with the ascending colon and is also a retroperitoneal structure. It's this segment of the colon that is very large and very dilated because it has to accommodate for so much high liquid volume coming off from the ileum. But then again, as the cecum is bulged and dilated and begins to absorb water, this huge dilation ends up coming back down to normal size as water starts to be reabsorbed. The next segment right here is the ascending colon, and this is also retroperitoneal, and it pretty much just spans from the cecum all the way up to the hepatic flexure. The cecum is often sometimes considered to be a part of the ascending colon. The next section is the transverse colon. So the transverse colon is also a portion of the large intestines that helps aid in water reabsorption. It attaches from what is considered the hepatic flexure, with the liver being here, the splenic flexure with the spleen here. The difference between this portion versus the ascending and descending is this is intraperitoneal. So this right here is in the peritoneal cavity. Then you have the descending colon. This is again ends up being retroperitoneal, and it spans from this splenic flexure and all the way to where the sigmoid or the S shape begins. So this, as soon as you start having this S-shaped structure right here, this right here where this S shape is the sigmoid colon, and it's also retroperitoneal. The last section is the rectum, which is retroperitoneal, which we'll further discuss in the section on the rectum and anus. And this rectum is the terminal segment of the large colon, and this is where actually stool will eventually be stored in preparation for ventral defecation. Now we'll again discuss in brief the blood supply of the large colon. So the SMA, again as we mentioned, provides blood to the jejunum and ileum. It also provides blood to the cecum, the appendix, the cecum, the ascending colon, as well as a portion of the transverse colon. The transverse colon is unique because it receives blood from both the SMA and the IMA via an artery, marginal artery of Drummond. So for any reason, if there's an occlusion here or an occlusion here, the transverse colon may still end up actually receiving a satisfactory amount of blood. The descending colon, however, only receives blood from the IMA. The sigmoid colon, again, only receives blood from the IMA. And the rectum, as we described, will receive blood from both the IMA and it will receive blood from the internal iliac vessels, both as the middle rectal and the inferior rectal vessels. So now we'll discuss these final clinical pearls. So while we discuss the appendix, it's important to discuss the mechanism in which appendicitis occurs. So appendicitis, itis being inflammation, is when an inflammation occurs, an infection occurs at the site of the appendix. So appendicitis usually arises due to some sort of obstruction in the appendix outflow. So although it's hard to describe it, hard to show in this image, the appendix is pretty much a blind pouch. So what happens is if a stone gets stuck in here, and by stone it could be a fecal lift or some sort of fecal impaction, there's going to sort of be a buildup of pressure distal to the site of obstruction. This is an intestinal structure, so it also contains mucus-producing cells. So as mucus builds up in here, the pressure starts to increase. Since there's no way for this pressure to go, it will end up compressing blood flow out of the appendix, then eventually going to lead to increased susceptibility to bacterial proliferation, inflammation, possible infection, and eventual perforation of the appendix, causing appendicitis and requiring emergent surgery. The most common surgical technique for this nowadays is laparoscopic appendectomy. However, in certain situations, an open appendectomy is required. So the next clinical pearl is colorectal cancer. So colorectal is a very common cancer today with often devastating consequences if not caught early. So colorectal cancer kind of has these unique hallmark presentations that people often pick up on in the clinical setting or even in a clinical vignette. So one of the most important things to pick up on is someone who has a blood test done of their stools. It's called an occult blood of the stool. And what occult means in Latin is hidden. So when their stool is analyzed, they look for kind of like this hidden or microscopic blood. And the reason why that happens is because wherever these little polyps or these little cancer arises in the colon, it requires angiogenesis and the formation of new blood cells. These new blood cells are not strong blood cells, and so they're kind of weak. So any sort of manipulation or sort of trauma to these blood vessels will allow for release of some blood into the stools. So if someone comes in with occult blood positive and they're also iron, remember it, iron deficiency anemia, then you're thinking that this person may have something like colorectal cancer, or at least high clinical suspicion for colorectal cancer requiring further workup. Most likely that will include a colonoscopy. A colonoscopy, again, is the most important diagnostic and therapeutic method to help prevent/treat colon cancer. Another important aspect before you get to a colonoscopy is the size and color of the stool. So individuals that may have a ascending colon colorectal cancer, they will have normal stool caliber or size. However, they could have melena or occult blood, or so essentially they could have darkened stools. Or they could have a descending colorectal cancer, and that's because there's an obstruction occurring right here or right here. So the stools actually have to become thinner in order to pass through, so then they'll become pencil-shaped size. So again, back up to the colonoscopy. The colonoscopy is important because what they do is they take a little wire snare loop, they can wrap it around and polyp, and they can kind of cut it out, send it to pathology, and see if it is at risk for malignant potential or if it's just some sort of benign polyp. If the polyp or the mass is too large, then a CT scan is considered in case it has some sort of malignant potential to see if it kind of spread anywhere else into the lymph nodes. And if it is a size that is manageable, then a colectomy may even be recommended to kind of cut that out. Last clinical pearl we're going to talk about are the abdominal recesses. So these abdominal recesses, these are little locations in the abdominal cavity or almost little pouches in the abdominal cavity where fluid and infections can kind of collect. So depending on where you are in the abdominal cavity, you can have specific sort of recesses. So you have your left and right subphrenic recesses, which kind of occur right here. That kind of occurs between the diaphragm and the falciform ligament of the liver. You also have your subhepatic recess between the liver and the transverse colon. So it's right here. You have your pericolic recesses that are located on the peripheral side of the colon. And then you have your vesico-uterine pouch, which occurs between the bladder, vesico, and the uterus, uterine pouch. And this is considered the most inferior recess in the abdominal cavity for a woman. And this is where actually gravity will actually pull fluids and contents down and it will reside. So individuals that may have a splenic laceration like we mentioned before, or a liver laceration like we mentioned before, the blood will actually accumulate in this most inferior portion of the abdominal cavity. And that concludes this section of DaVinci Academy.